Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Mount Sinai Fuster Heart Hospital cardiac catheterization at New York City. My name is Pedro Moreno. I'll be your moderator today. Remember, we like to hear from you. This is an interactive experience, so please send us your questions directly on the website or on YouTube. And this afternoon, you can review this case and all the previous cases on our website, ccclivecases.org. Now, let me transfer you to the cath lab for a very interesting case.
All right, Pedro, and of course, viewers of our CCC Live structural part, welcome from Mount Sinai Cath Lab. Bright and very cold morning. Many places, I'm sure they are very warm. But myself, with my other associates, Dr. Gilbert Tang, Dr. Anpurna Kini, Sahil Khera, as attending the interventional and surgical attendings. And
show
then
the slide.
we have
Slide.
Yeah, but then Lucy is our on the echo, and then we have two interventional fellows, Pratish George and Maria Elena. So with that note, we actually, this is a little different type of case in the sense we have shown a lot of them, valve in valve, valve in TAVR, and so forth. So we wanted to just show this time a bicuspid, which is going on quite a bit. Yeah, the bicuspid case, which knowing that this field is still evolving, and soon we will have a trials. Actually, I just got a call last week. Raj Makkar is starting a trial of the appropriate bicuspid aortic valve with TAVR versus surgery. There is no as such trial of the bicuspid. Bicuspid was a part of the studies, all that then we had done, but there's a one arm, suitable cases, but as a single arm. But now the randomized trial. So these are our faculty involved. You see it here. Pedro, of course, moderator, and cardiac anesthesiologist is Emily Fang. With that note, this is the case. A patient with severe bicuspid aortic stenosis, and with the plan is using a 23 plus 2 cc SAPIEN Resilia. This is our episode number 75, 69-year-old male. You say, well, it's a low-risk patient. Why are we doing a TAVR? And I'll go through it. Presentation with the dyspnea, and of course, advanced New York Heart Association classification, good medical therapy. This patient, actually, if you see here, we have seen a progression of bicuspid AS over the years, and also had a CAD PCI a few years ago, and today coronary again was fine. But patient has multiple cancers, remote bladder cancer, then prostate cancer, then lung cancer, and that really made him very high in terms of the comorbid conditions. STS is low, but comorbid conditions. The ECG is sinus rhythm, and aortic, we'll just talk about it, what exactly is in terms of the bicuspid severe aortic stenosis and high gradient. We actually can show what we obtained now. This patient, we did a TE. Reason for TE was?
Oh, just because low risk, we want to make sure we can see the bicuspid anatomy well, and also the paravalvular leak. Okay.
So majority of our cases are 90% plus are done without intubation, and no, this field is all evolving and more going away from anesthesia. Latest trial did show that once you don't give anesthesia, the patient do have more discomfort. That the choice trial and so, but overall people are going away from anesthesia. I mean, particularly TE, except rare cases like patient with a low ejection fraction. And what else will be the case where we'll use a TE?
So, valve in valve.
Valve in valve, okay.
Rarely TAVR, right? And if, of course, you have to do your special devices to do modification of the leaflet.
In those cases also we're using intubation. Okay.
Yeah.
So basically,
so
I mean, clearly we know the intubation gives us a more controlled atmosphere, environment for dealing with these tough cases. So if we show the active echo now before we go on to this presentation. This is active. So Lucy, it's yours.
So this is live echo. You can see 4-chamber view, normal LV systolic function and normal RV systolic function as well. This man had no other significant valvular disease, so here's a 3D of the mitral valve. You can see leaflets are nice and normal with minimal mitral regurgitation. Also had minimal tricuspid regurgitation as well. Focusing now on the disease, so aortic valve, you can see a beautiful fusion there of the right and the left, which is the most common, and the raphe here around 5 o'clock. So heavily thickened and calcified bicuspid aortic valve. There was no significant aortic insufficiency that was seen, both on 2D and also here on 3D. You can see again that beautiful raphe around 5 o'clock, the fusion of the right and the left, and with color Doppler. Quantifying now, you can see LVOT diameter 2.1, and then this is his LVOT with a normal stroke volume of 72. His velocities across the aortic valve were about 4 meters per second, and then peak and mean gradients noted there, giving you an AVA of about 0.7 and an index AVA of about 0.4, consistent with D1, severe aortic stenosis. Here on 3D, we got our perimeters. So our area was 4.1, similar to the CT, and right coronary height here about 19, and left coronary height about 12 millimeters.
In terms of the bicuspid, what is the anatomy? Is it favorable anatomy or very hostile anatomy? What do you think?
Based on CT. It's more on CT.
Okay.
Let's go on the CT.
But this is here clear cut as the bicuspid. Okay. So let's go to CT presentation. Let's go over our slide presentation. Okay. So the echo has been done. Now this is what we have. LVOT. Sahil, you want to comment on?
Sure. The annulus is pretty reasonable. The average is around 24. I don't see any annular LVOT calcification. LVOT tapers down to an average of 22. Next slide, please. Yeah. STJs are pretty generous. The sinus of Valsalva is pretty big, and this is what we expect in bicuspid, small annuli and mostly big sinuses. The left main and the right coronaries are pretty high. So I'm not concerned about coronary obstruction. I'm not acutely concerned about rupture risk. So it seems like favorable anatomy. Can we also see the leaflets? Yeah, so leaflets are severely calcified. You can see it, big chunks of calcium. So yeah, you may not have annular or LVOT calcification, but these leaflets itself, if the sinuses are not capacious, you can have sinus ruptures because of these bulky leaflets. So that is something I would be concerned about, but here the sinuses are pretty big.
Okay. And this is a little more on that.
And you can see the fused left and right raphe, and the raphe is not calcified, always a very good sign if you're selecting these patients for bicuspid TAVI. If the raphe is very calcified and the opposing leaflet is very calcified, those are called T-bars, and you should stay away from doing those transcatheter.
So therefore, it's although bicuspid, but it's a favorable anatomy, right?
Yes.
Anu, that's
Yeah. So if you see that
CT.
fused raphe, but no calcium in the raphe, most of the calcium is just on the leaflets. So maybe one of the better part of the bicuspid.
Good.
Various.
Okay. Peripherals looks all right. So
Yes.
there's nothing unusual there. And then CT. So question is, we are presenting this largely because of the Sentinel device. Why we should be using Sentinel in this particular case, knowing that Sentinel numbers have become in the single digits now. So what will be the indication of using Sentinel in this particular case?
Sure, Gilbert, you want to answer that?
Yeah, I mean, this is a low risk bicuspid, very, heavy leaflet calcification. So we still feel that, trapping any debris is, better than trapping no debris. So, and also the patient was very well read, well informed, and he said his preference, if feasible, would be to do it for him.
Yeah, so earlier data did show there is a conflicting, always there will be a different report, but earlier data did show that the bicuspid has a large, more CVA in early time, of course, within hospital, and largely because of this embolic, that lot of this calcium debris, which goes up. So, and they have done the intracranial Dopplers also, showing the large shower of emboli with the bicuspid aortic valve, TAVR. So therefore, our goal is that if it's a low risk, highly calcified, bicuspid aortic valve will use a Sentinel device if there is no contraindication, right? What is the other condition where we'll use a Sentinel now?
So there have been some discussion about valve-in-valve, especially if you plan to do leaflet modification or fracture, that there might be, prosthetic valves are very different from native valve. once you have exposed, the debris inside can certainly have a risk of embolization. So that's another area.
Some people do say when you do leaflet modification, everybody should have a sentinel device. Is that a right statement?
Well, if it's possible, right? Remember, sometimes the complex access, we might need the radio access to do certain things as well. Like, for example, protection. Because just because you modify the leaflet doesn't mean that you guarantee no obstruction. So sometimes we might still need to protect. So that's why it is a case-by-case basis. I don't think we need to make a blanket statement necessary.
Okay. All right. So summary of the case: bicuspid severe aortic stenosis, mild other valvular disease. STS risk mortality is only 1%. But after heart team discussion with the surgeon, of course, Gilbert is a surgeon, but in these cases, low risk, we get to our aortic surgeon also. This was recommended to undergo balloon expandable TAVR given oncological comorbidities, because patient has a cancer, then chemotherapy, the surgical therapy. Everybody felt that if we can do a TAVR, will be good case, and particularly use Resilia, and hopefully that will give him 15 years. So he's 68, 15, taking to 82, 83. By the time we may have some new technique. And so that's our plan with a 23 millimeter plus 2 SAPIEN with a cerebral embolic protection device and with the femoral access. And femoral access they can show. Now we can go to the angiogram. Pedro, any questions have come up and anything from your side?
No questions, but
can we go live to the? Yeah, perfect. Thank you.
I think the proper explanation of the hostile anatomy and the presence or absence of the raphe with the calcification clarifies the issue on the selection cases when they are needed.
Yeah, I think the other question here is, the lifetime management of this patient, 69-year-old. So bicuspid, typically, as Sahil mentioned, bicuspids have a more generous anatomy, but there are cases that might not be as generous. So this is a very important discussion with the patient in terms not just the raphe classification, annular LVOT classification, but also if you do a TAVR now, number one, we don't know the long-term durability because most of the randomized trial are tricuspid. And two, can you potentially have a re-intervention with another TAVR device in the future? And if the answer is no, then surgery should still be on the table, especially once you put a surgical valve, you can certainly consider a valve-in-valve TAVR later on. And especially if you put a small TAVR device which have risk of severe PPM, in this case not true because this patient is not obese, then you might want to consider surgical root enlargement and then do a valve-in-valve TAVR later. So there's a lot of different options, at least in a center like Mount Sinai, where we have excellent surgical and transcatheter options for both patients.
Okay. Now, one additional point is coronary artery disease.
Yes, absolutely.
If there was extensive coronary artery disease, just like Gilbert just mentioned, again, surgery should be considered in those cases. So you can see the angiogram was done today. He said prior, this is the left system, everything is non-obstructive, and right, he did have a PCI before, and the stent is patent.
Good.
So we want to stimulate our audience to see if they do the same, if there is any issues about procedures on selection. Most importantly, what do you think about the association of the bicuspid valve and the aortic diameters in the ascending aorta?
That's a great point, Dr. Moreno. So one thing we did, one should measure the CT here. So the CT ascending aorta is around 4.3 centimeters. So this is less than the threshold 4.5 centimeters threshold for surgery, concomitant aortic ascending aortic replacement. So that's something that obviously we are very cognizant of. And also, I think from a procedural standpoint, with dilated aorta, you want to make sure all your catheter and wire exchanges are done with a pigtail or wire, with a catheter, with a wire. You don't want to just pull and push catheter and wire blindly, because obviously that can cause an acute aortic injury. So that's something to be mindful about when you do TAVR in this population. One of my residents recently recently just presented at AHA some of the data on what is the kind of a long-term history in terms of patients who underwent TAVR with bicuspid ascending aortic dilatation. And interestingly, the incidence of acute aortic events such as dissection or later on subsequent surgery is actually extremely low. So this is reassuring, I think, and also a number of papers published in the highly regarded journals like JAMA or Lancet has shown that for bicuspid TAVR in registry manner, the incidence of reintervention from an aortic standpoint is also low. But if the patient is low risk like this patient and the aorta is dilated to meet the criteria for surgery, they should definitely go for surgery. There's no question about that.
Great.
Absolutely,
We have
yeah.
a very good question here from Saurabh Akstam. He's asking if we use balloon TPI or a regular TPI for pacing. We
Always balloon tip, 5 French. It's a 4 French balloon tip PCI. Pacemaker, and you bring it down, and this is where a lot of people are worried about pacemaker causing perforation. And I can tell you, we now have maybe 10,000 plus pacemaker over the last 20 plus years for various regions, and we have 0 perforation because there's a balloon tip 4 French pacemaker, and you make a shape. And so that is the very important point. And secondly, which Gilbert pointed out, the aortic root, aortic dimension has to be 4.5 or below to be randomized in the trial. So I just got the trial, the preview of the bicuspid. It has to be 4.5 or below, and favorable anatomy from the for that both surgeons and interventionalists feel it's a favorable anatomy for the TAVR. But yes, 4.5 and below. And this patient was well below 4.5, like 4.3 or so.
But that's right. And also, obviously, sometimes you index to small patient. This is not a small patient, so that you keep that in mind as well, because obviously the risk of acute aortic event can be high.
So let me ask a question now that we're discussing about aortopathy.
Can
What
we show
happens
the
to these
gradient?
patients after TAVR? So what happens to ectasia? So this is ectasia. What
Right.
if patient has borderline aortopathy? Does the aortopathy progress?
So
Does
exactly,
anything
so
happen?
that's a good point, though. I think some literature has shown that the incidence of intervention on the aorta itself is low after TAVR, which is reassuring, I think, in this context. But obviously, these are carefully selected patients. They don't have aortopathy to start with. We did have years ago an extreme surgical risk patient with type 0 bicuspid and aortopathy, and we did the TAVR because the patient was inoperable and, of course, had an acute aortic event because of, once you relieve the AS, the pressure from the left ventricle can be quite high. So the key for extreme surgical risk patient who underwent bicuspid TAVR is to control the blood pressure immediately in the peri-procedural and post-procedural period, because they do have an aortopathy that's untreated.
Okay, Anno, tell us now what you're doing.
No, we just crossed. So crossing aortic, bicuspid aortic valve could be challenging, depending on the size of the aorta. We used AR2. And that's what I think we were trying to show. I don't know if we documented. No, we don't have it. So here, always go to the, aogram. You can see if there is a valve opening, which is, and then based
Let's
on
say you selected AR2 in this case. Why not AL1?
came out. Wire came out.
The wire has come out here.
Yeah.
Let's get the...
What will make it for you to go with the AL rather than AR2?
No,
which
we
is
always,
the usual?
Yes. Here it's not a dilated root. What happened?
No, don't loop the wire. Then it's...
But is a cutoff, you'll go with a 4.5, 4.0, what will be the cutoff to go to AL1 as a first catheter? We know that sometimes you change the catheters. AR2 is our standard catheter. Actually, when we were trained, for the tower, when we, the whole, I'm talking about early days of 2010 and so everybody was just going with the AL. And I told them that we have published the paper of the wire and the catheter. AR2 is the number one. And then, of course, things change, and now people use. But if you go back to the initial standard operating procedure of the tower valve in 2010, it was AL1. They made it that everybody should cross AL1. I said, wrong thing. Then they changed it to a catheter, whichever you want. Like this is the AR2, which you using.
Yeah, I think if your sinuses are less than 40, there's no reason to use AL1. I think AR2 should work. It's more of the sinus where it gets looped around rather than the aorta itself. So I think if it's less than 40, you should be able to use your AR catheters. If it's really bigger than 40, then you may have to use an AL1 or rarely even AL2.
Size is one. Other one is eccentric opening also.
Yes.
Sometimes that's,
Hold the catheter. Yeah.
yeah.
RAO, please. So you saw how she crossed, right? Went to the coplanar view, assessed the opening.
And go with the straight tip, stiff shaft Terumo 0.038, and not the Teflon. A lot of people still go with the Teflon. They are worried about that it caused perforation. And back then, 1993, if you see, randomized trial of aortic valve crossing, and we compared, and using the Terumo wire, the time to cross the valve became 1/3 compared to the regular straight tip Teflon that we were using at that time. So this is the time we changed it. There are a lot of pros and cons. After initial experience, we did the randomized trial, 3-center, and it came out to be only, one of the biggest difficult situation was crossing the surgical aortic valve. That is very challenging. That's where we, even the the straight tip Terumo was give very difficult and long time. But less than that, if you exclude the surgical, even your bicuspid, the chances that you cross in less than 3 minutes was like 98% with the Terumo, and it was about like 62 with the Teflon.
I think 3 minutes you should be able to do the TAVR.
Yeah, it's too long.
Yeah, but I think Dr. Sharma had a good point. For very calcified bicuspid, that's why the CT is so important. You might need to use other adjunctive
Can you show
tools.
the gradient?
For example, a guy is stiffer, and we actually use that to cross a surgical valve, like what Dr. Sharma said, with very large
Hemodynamics,
root,
please.
because you have more control. And Dr. Sharma always had a trick that all else fail, V18.
Yeah,
That's the finest wire to be able to cross, and you'll be able to do that, and then you can rail.
And those who are audience, and many of you might know, about 5-6 years ago, there was a case. I don't want to say the speaker's name.
No, but can we put it in the bottom?
Yeah, we see it. We see it.
Yeah,
No,
so
in the
they're seeing
bottom.
it. No, they're seeing the
It
aortic
has to be
gradient.
put in the bottom.
They're seeing gradient.
gradient.
Yeah. So they actually were supposed to do one patient as a TAVR, live relay in TCT, and it was 45 minutes, and they could not cross the valve and went off. But then, of course, later on they did and showed the end. But just to say, sometime it could be very tedious, particularly this bicuspid one. Although it was showed that how easily it could be, where you see the opening and just back and forth. Now
Any
you are
comments
actually-
on the projections that you should use crossing, let's say, prosthetic aortic valves?
No. It's
Same.
all LAO. All with the
All
principle
LAO.
remains the LAO. Yeah.
Get
Reason is
2001.
because you'll miss the wire going into the RCA otherwise. Because you'll never know that the wire has gone into the right coronary. Only LAO will tell you that you cannot, that you should not advance when it is pointing to the right or left ostia.
So Dr. Moreno, another good point for surgical valve heavy bicuspid. Another reason why we're using TEE is that it's very helpful, especially the TEE on a long axis view when you explain the short axis. And Lucy can explain that later. Really tells you how center the wire and catheter, and you should start doing that more often, especially you plan to do leaflet modification. Because leaflet modification, yes, is fluoroscopically guided, but also TE guided to make sure you split at the correct spot. Because coronary arteries may not come in the middle of the sinus. They can be offside, reface, particularly to the right. So it's very important to correlate that with TE where you're in fluoroscopy. So I know talk about minimalist TAVR, but sometimes you have to be perfect TAVR, not just
150.
minimalist.
Space 150.
And you tell them what you're doing.
Nothing, we're doing a BAV now.
Using what?
So 21 true
21
balloon. Push
true
the
balloon.
balloon in.
By why 21? Because your mean was 24.
Good. Sitting.
Yeah, so we don't need to, we just need to open the raphe enough. This is a balloon expandable platform. But I think you're right, Dr. Sharma. For self-expanding platform, I would be more aggressive, especially with the raphe. And always you look for the hemodynamic changes because sometimes the raphe can be stuck and you can cause acute AR, but it looks like the blood pressure now come back very well. And also you don't want to be too aggressive either. With balloon expandable platform, what the pre-dilatation does the two things. Number one, you can cross the valve easier. You don't want to be obstructing the outflow, especially let's say the patient have low EF and cannot tolerate that. And two, you want to be able to have better expansion and the index deployment. for both balloon expandable and self-expanding. And you'll see, we use a double tap technique now routinely for all balloon expandable, and our paper is going to be presented for the first time at London Valve this weekend and published in JAMA Interventions simultaneously on SAPIEN-3 Ultra Resilia using this technique, and we'll show you here today.
So Gilbert, the issue here, you are ballooning and expanding the raphe. That's the pathophysiologic aspect of the balloon.
That's correct. That's right. You want to open the raphe, especially when it's type 1, so that you can see how it behaves. Because sometimes you might adjust the volume of the inflation. Let's say the raphe is not opening very well, you worry about rupture. So it's very important to consider that, Dr. Moreno.
And can we see that in the TEE now before we put the valve?
Yes, you can see that on the pre-dilatation. If you have TEE, of course, you want to make sure, in particular case, in our case here, we want to go to the implant angle first to see sometimes if the TEE might be in our way. So for example, in this case, unfortunately, it's just in our way. So we'll ask Lucy to see whether she can still image. It's not bad. So this is pretty good in terms of looking at the...
Show the echo.
Okay.
Test. Okay, good.
Okay,
good.
So let's see the raphe here.
180.
I think it's open.
1 second.
Yep.
It's open.
Yep.
That's a PVC. It's not capturing properly.
Good. Off. I like the depth there. Actually.
It's not capturing the
Pedro.
TVB.
Can you see it on the
Make
TE?
sure the TVP is
100%.
okay.
Yeah, I like
you're
it.
convinced?
Now
Okay.
now you are a tricuspid valve now. You converted a bicuspid congenital to a tricuspid, opening very nicely in the center.
It was not.
Okay. Ready?
Everyone likes it?
Yeah.
Okay.
180.
180.
Take the picture.
No, we leave it nowadays.
Huh?
Cine and inject.
Why inject? Huh?
Inject. Okay, off.
Are you testing again?
We want to make sure the capture is again.
Okay, good.
180.
180.
Lungs down.
Full, right? Did you really?
Back up now. Good.
Lungs back up.
Lungs up.
I think you have to go 1 more cc.
Yeah.
No?
Let's do an aortogram.
Let's do an
Then Lucy, TE up for a minute. Please. Actually, hold on 1 second.
TE coming
Yeah,
up.
do one more. I think you need one more here.
Press
Okay,
on
good.
it.
Let's take a...
No, that's okay. You can use TE.
See?
Fully plastered.
Yeah.
Okay, give me 1 more cc.
Or maybe
Not even
2.
that.
Let's see. Can the T guide us, Lucy, that what we do next now? The same size, bigger size, in terms of valve expansion, any PVL?
Yeah, so the leaflets look, first of all, the leaflets look thin, freely mobile, they're functioning normally. There's some wire-related central AR, which is expected. And then there's very minimal posterior PVL.
Okay, let's go.
that
180.
actually-
Okay, let's pace 180.
Full. Stay on it. Okay, so
Keep pacing.
Back up.
you see the second inflation?
Looks much
Could you
more.
see the difference, Pedro?
You can take it off.
100%. Beautiful
That's
the one.
expansion.
Yes.
Yeah, and you can see it on
All the way
echo
out.
too,
All the way out.
much more
Picked it?
expanded on
Picked
echo.
it? Yeah. Okay.
All the way out.
We have a comment from Dr. Surab Akstam. He's saying, do you regularly use TE for bicuspid anatomy? Do you feel there is incremental benefit of it?
Good question. So, so let me answer that. The answer is no. And it depends on the risk profile of the patient, right? Always go back to the risk profile of the patient. If the patient is very high, extreme risk, and the anatomy is benign, there's no need for really TE. In this particular case, patient is 69-year-old, low surgical risk. We need to eliminate PVL if we can, based on this anatomy. So in our mind, TE is the best imaging modality to evaluate that.
Give me a J-bar.
Why you need
Now,
it?
another question or comment here. Another comment from Dr. Wakar. If unable to cross retrograde for bioprosthetic, going transeptal and anterograde and snaring may be a good trick to do it under ice. This is just a comment.
Yeah, so no, the question is the antegrade crossing of the valve. So I can tell you, I said, having done whatever crossed over the life, maybe 10,000 valves. We never needed antegrade crossing. The key is V18. Listen again, V18 will get you in these difficult situations. The V18 wire.
So they're talking of prosthetic for AVR,
Any one of them,
surgical
any one of
AVR.
them, any
Now,
one of them.
usually TAVR valves somehow they're easier to cross.
Yeah.
No,
Even
I'm
with
saying that
pigtails,
any
but
valve,
surgical valves,
the surgical valve, difficult case also, it will be that you use V18 wire. Now, we know that whole TAVR, you remember the first case?
Absolutely.
First case
Yeah.
was done antegrade, transeptal,
100%.
and they did, and of course you can always cross it, but there would happen in the first case was fine. Second case, patient went into cardiogenic shock after successful TAVR with Ellen Cribier, and they realized patient had a severe MR because that the wire in the ventricle cut the chordae, and patient developed severe MR and did not have a good outcome. So antegrade was very quickly abolished. But just to come back to point, which case would you use the antegrade? To me, is this day and age not necessary because we have enough equipment. Using particularly the V18 wire will be good enough.
That's the
Very
final
good comment.
gradients.
Final gradient was 3.
Continue 1 minute.
So you can see on the hemodynamics screen as well that is no gradient. And AR index is excellent in terms of regurgitation. And we can do one final aortogram for the audience if you like here.
Yep.
Lucy,
0
T probe up,
PVL.
please.
Yep. T probe coming up.
Nothing.
So the other thing that we've now done as well, let me just go for the audience sake, is to go in a more aerial caudal projection to see how expanded is versus the two view. Because sometimes with raphe, one raphe, so this is aerial projection.
So echo showed no PVL, right?
Ready? Okay.
No PVL.
Ready?
Okay, go.
Oh, can we
Oh.
make sure it's not? Okay.
Perfect.
Look at this
So,
lap.
high
This is the
deployment.
cuts overlap view. Okay.
High
So,
deployment, no
yeah.
PVL, almost.
No conduction changes.
Yeah. And
Remember,
gradients of
bicuspid have higher pacemaker rate. People ask, say, why? Actually, in surgery, we know because the membrane septum is actually shorter. So that's why there's a higher pacemaker rate. And also, as Dr. Sharma mentioned, higher stroke rate because there's more calcific burden on these valves. So,
Now-
and in Asia especially, we've seen
40 protocol.
a lot of them have very, very hostile calcification.
Now, what about some people there are some papers in the literature about non-circular opening of the aortic valve. So that cause more degeneration in the future. I know where is the commissural alignment is one of the factor, but is a very eccentric opening. So that's why the my valve hectocore is designed for that. That in these cases, you rather than having this our usual that settled with the whole sinuses and so any concern about, I mean, we don't pay attention to it.
Well, that's very good point, Dr. Sharp. That's why we did the other view here on the aerial caudal to kind of have two orthogonal views looking at the frame on the fluoroscopy now for bicuspid, especially for not just self-expanding, which we know obviously conformed anatomy, but also balloon expander, as you pointed out. We had done some post-CT early in our experience to show that some of them are not circular, as you said before. But of course, that was before we also started doing double tap. And you can see fluoroscopically here, there's no question that the valve expanded more after the second inflation. And we added only 1 cc. This is a semi-compliant balloon with the Edwards system. Sometimes some people might even use a non-compliant balloon to optimize the expansion.
The same thing you go back with the true balloon.
Yes.
So
Now-
from our audience, SS, Dr. Wakar, who mentioned the anterograde crossing, is telling us, what about when you have a small trifecta and a large root with a very stenosed valve?
Pay attention.
Would you
no?
always
V18.
do
V18.
retrograde in this
V18.
case?
100%.
V18. V18. Okay.
V18 wire.
So one teaching point, and I've been teaching my fellows also, use a AL guide.
AL guide.
AL
and
guide
V18.
is the trick. No one is doing retrograde nowadays. People have moved away from it.
No, we
AL
cannot.
guide.
Anterograde.
Yeah.
Sorry, antegrade. Yeah, AL guide, put it right in the center of the valve. You can use your TE imagers to help you out. Just like you do a basilica, on FOS into the valve, and you should be able to cross.
And let me tell you another trick. If by you did everything possible, could not, use the electrocautery. the transseptal, because you go through the leaflet. Remember, there are actually papers now that you go through the leaflet to cross the valve in particularly aortic regurgitation. Because so that valve sticks, from the Cleveland Clinic, they publish case reports that they go through the leaflet actually, and so that now the valve will not embolize, particularly in the pure AI. So you can go through the leaflet, it's not a problem.
Wonderful.
You puncture the leaflet with the cautery, and then you put your exchange, and then you put your valve is now.
So it's
not
very
moving.
interesting, Dr. Sharma. That's actually the birth of unicorn.
Yeah.
That's the concept of prostatic valve. You basically, because of coronary obstruction, that you can displace the leaflet completely. Of course, it's still, we need more data, but this is the same idea that you cross for native anatomy for the same kind of concept. But of course, you need a balloon expandable valve for that, to be able to do
balloon
that.
expandable. So just to say, our esteemed colleague who is asking the question, no need for antegrade. If you need to be, you can just go through the leaflet with a cautery and you'll go through it. So with that note, let's go to our presentation.
You need to be.
The few things have come up in the TAVR field. One is the partner trial, 7-year data, then NYHA trial of the TAVR versus SAVR in women at 1-year follow-up, then national NOTION 2 trial, results at 3 years, then ICARO study of the IVUS for coronary obstruction and the TAVI effect on epicardial microvascular indices. So a little different presentation I'm making this time. The partner 3 trial, remember that it was a low risk patient, the SAPIEN, various types, SAPIEN XT and SAPIEN-3 were in the trial, and they were randomized against the surgery. All were the trans-femoral, very good data up to 3 years, and now the 5 years. And you see exactly identical all the endpoints of combined death, stroke, rehospitalization, or individual endpoints were exactly identical at 7 years. Very, very reassuring. So remember, we have the trial data of the 10-year, but now we have the NOTION trial of the 10-year plus, and now we have 7-year done in United States, knowing the other one done in the Denmark and others, that we have a great the data of the 7-year follow-up. Only one, which two things we always used to worry about. That one, is there a difference in endocarditis? Second, is there a more valve degeneration? And answer to that is no. Valve AV intervention identical, endocarditis identical. Only thing we lost is valve thrombosis, and valve thrombosis at 7 years, and in the SAPIEN valve was 2.8%, it was 0.5% in the surgical valve. That was statistically significant. Everything else is same. Of course, pacemaker is slightly higher, which we knew about it, but the key is that there is a valve thrombosis, and this is somehow a little more to SAPIEN. We have data up to 5+ of the balloon expandable with the evolute. There is no difference in valve thrombosis, but this is a negative point. Second point, in terms of the valve area, once whatever you got until 7 years, exactly identical, 1.8, 1.9. There were no degeneration takes place. I mean, the loss of, our volume of the valve opening takes place, and bioprosthetic valve failure, as I mentioned, exactly identical in both. So now if anybody make a claim, the surgical valve is better than TAVR valve, we can say now in the large randomized trial of the low risk patient at 7 year, exactly identical valve failure and so. So this is great news for us. Second, the NYHA trial, that is, what about the women? They always talk about that maybe patient do badly with the TAVI versus surgical valve in a female. So we have the data, low risk TAVI, low risk aortic stenosis patient, randomized to surgery versus the TAVI. Risk was 2.1, so low risk clearly. And you can see here, the outcomes of the TAVI were superior compared to surgery, and largely because of rehospitalization. No difference in stroke, no difference in death. So lower rehospitalization, and of course there are some did happen in the vascular complication, which we expect. The bleeding, of course, was lower, pacemaker was higher, new onset AFib was lower, but overall it seems to be that in women with a low risk, TAVI is favored over surgery. We know that the low, small annulus point of view, there have been data of the self-expanding valve. Gilbert, anything you want to comment on this?
Right here is that obviously surgery has more AFib and more bleeding, and bleeding might not be a good thing for anyone, particularly women who have small body surface area. We know that can cause a hemodilution. So I think that is the key. And of course, you want to avoid PPM as much as possible, which we don't account for here. So
right. So that is a very interesting point of the. So overall, as you can see, good outcome of the women. It's a 1 year only. They had to go a little further. Then the Notion 2 trial, which was the surgery versus TAVR done in the United States in a younger, low-risk patient from 60 to 75 years of age. Low-risk patient involved all tricuspid and bicuspid. Bicuspid was about 25%. These patients were randomized and followed and basically showed now at 3 years, as you can see, that exactly identical outcomes. Now, I want to just take you back to the 1 year outcome of the Notion 2. Tricuspid on the left side, bicuspid on the right side. Look at the difference between the surgical and TAVI. TAVR group had a higher problem in the bicuspid, not in the tricuspid. Now what happened now? If you see here, this is basically the tricuspid or bicuspid cohort, now no longer is statistically significant. Yes, surgery is a little bit favored, as in the right side lower panel, but overall now no longer that significant difference which was noted at 1 year. Now maybe some patients died or have a reintervention, but just when you follow those patients, overall the non-statistical is still favored surgery, but no longer statistical in any of the points. Death, MI, stroke or rehospitalization remained slightly favored, but nothing significant. Now, as you see, the patient, both groups, actually valve performance and durability did very well. And follow-up of these patients, and particularly in advanced classification class, very small group, Kansas City also remain fine. The only question comes down to that some cases where you have a valve, the patient prosthetic mismatch. As you can see, the bioventricular, bioprosthetic valve failure was higher in the surgical valve because of the baseline patient prosthetic mismatch. So that's a different story, but valve degeneration was exactly identical and the rest of the outcome. So we now have 3-year data of the patient age 60 to 75 with a severe AS who are at low surgical risk. 3-year clinical outcomes are similar between TAVR and surgery. Both procedures are associated with low rates of structural valve deterioration and need for reintervention. Then we have a study which is kind of the case which we have, and particularly more happen in the valve and so is there a role of IVUS to identify which coronary obstruction will give you trouble? And this was the multi-center study from Italy called ICARO, and basically what they did is basically the patient with the high risk. Gilbert, show it what it is. Yeah.
So
you want to show that?
Yeah. So we always look at whether the embolic protection device did anything in terms of the filter, but I don't know if we can put it in
they can show it.
There's
a ceiling
here.
Camera.
There is we did capture that. You can show it.
It's actually interesting that you see all these things being captured, but the trials have been consistently negative.
That's right.
Very interesting.
But at least
that's okay.
we're assuring that you can see.
No.
Can you show in the camera?
I will not get it. Move it.
That's
okay. So when do we get coronary obstruction? One is the native valve, when your coronary ostium is less than, height is less than 9, or sinus of valve salvo less than 30. And of course, leaflets extending beyond the STJ. And in the valve in TAVR, the patient bioprosthetic, which is supraannular position, low-lying coronary ostia, narrow sinuses, valve to coronary sinus distance of 4 millimeter, less than 4 millimeter, and so these are the high-risk patients with the coronary obstruction. So what these investigators did is that before we put a chimney stent, whole case was that we are going to put a chimney stent because there is a very likely obstruction of the coronary artery, and so before putting a chimney stent, they had a wire, of course, and then after the valve deployment, then they did a IVUS again to decide what to do. And this is a particular case, as you can see, that the valve impinged on it, and this patient underwent the chimney stenting, and the last lower quadrant picture is after the stent, nicely open. So they actually have went to various aspects of which patients get into it, and more importantly, that here, all types of valves were used in this particular case, and chimney stenting was done in 16 of the 40 cases. Now, other one, 32, 34, but actually two immediately coronary obstruction got the chimney. So 18, so 32 of these patients, 22 of these patients did not get the chimney stent which they planned to. And therefore, basically what happened is that, of course, even some cases done after the basilica, and they have the all description of those cases. The basically is that by doing the IVUS, you are able to see the ostium of your coronary artery, and you avoided putting a chimney stent. And this is, you can see, in the 26 of the 38 cases, you in 36.8%, you avoid putting the stent where not necessary. And so IVUS for the angiography, as you can see, there is a different correlation. And basically, these authors concluded overall outcomes was very good on these patients, whether you stent, 15, 17 you did not stent, outcome remains similar. Basically means there was no delayed coronary obstruction when you decided based on the angiogram and IVUS that don't put a chimney stent. So this basically is the learning, although we don't use it IVUS to make that decision, but these are all the new things which are coming up to avoid coronary artery obstruction, and the management, they have the nice algorithm based on the that one. Of course, immediately you closed, you had to put a stent, but otherwise you can have a time, deploy the valve, and then do the IVUS imaging, and then you look at your obstruction, and the length of the leaflet will tell you, will cause the obstruction. Those cases get chimney, otherwise don't. So basically they concluded that the first multi-center investigation on the IVUS used in the setting of coronary artery obstruction during TAVR suggests that the technique is both feasible and safe. Implementing IVUS in decision making on the need for chimney stenting may provide additional information, helping operators limit the stent implantation only when really needed. So this is basically the addition of it. The last one we always talk about, what about the functional indices? This is the first time that paper came, the effect of TAVI on the epicardial and microvascular dysfunction. You see that RFR and FFR get decreased after the TAVI. Say why? Maybe there is, part of some embolization happened into the coronary at the micro level, and you can see here, particularly those who develop coronary microvascular obstruction, the FFR, IFR decrease more compared to did not have a coronary microvascular obstruction. And this basically, now PDPA, resting indices did not alter at all. So basically, and there was a lot of concordance and discordance in terms of whether you check based on the FFR or based on the PDPA, which is IFR, and basically showing that FFR and IFR decrease after TAVI, CFR increase only in patients with when there is a dysfunction at the baseline. Then RFR and PD resulted in a higher proportion of significant lesion compared to FFR. So basically was that it was more positive in more cases. And the lastly was pre and post TAVI FFR values showed better agreement than PDP and RFR. So key is that TAVI is associated with a small but significant reduction in FFR and IFR immediately post-procedure. Overall, the agreement between pre and post-TAVI values, FFR was very high. And so with that note, let me just conclude. The low-risk AS patient in the partner trial showed very good results. Exactly identical. Only time we lost is for the higher valve thrombosis. So we have to think about what to do, particularly cases, appropriate cases may get us some small duration of the anticoagulation, but that's skeptical. Second, woman with low risk AS, TAVI was better than surgery, and of course largely because surgery has a more bleeding. And the patient prostatic mismatch. Then 3-year follow-up of the younger low risk in the Notion 2 trial showed that similar outcome, but I would still have to take this as a grain of salt because numerically events remain non-significantly higher in the bicuspid cohort, which was 26% of the total group. So be careful with the bicuspid. As I mentioned, this case was bicuspid, and there is a dedicated randomized trial. It is being planned at this time, and will be part of one of the 40 centers for that, of the bicuspid aortic stenosis, randomizing to the TAVR versus surgery. So our assessment is very helpful, particularly decision making, who should get stenting or not, and many of the cases do not do a routine stenting, decide that. And TAVI is associated with a small but significant drop in FFR and RFR, and I think to me Many of these patients did feel very good. Some of them continue to feel chest pressure. Is it because of this microembolization? Maybe. So this is one of the mechanism, despite a good EF, 100% working valve, at 30-day patient come back and they feel that, you know what, I'm still a little short of breath, I'm a little chest pressure. Is it this microembolization causing this? Need to be evaluated in few other trials. So 3 questions. Following statement is true about partner 3 trial. Not true, basically. Similar death and stroke rates, similar valve thrombosis between 2 groups, similar disabling stroke, similar endocarditis. Answer is not a valve thrombosis, because valve thrombosis was higher in the TAVR group compared to surgery. Second, RHEA trial comparing TAVR versus surgery in 1 year low risk AS female. Patient showed the following except that what is wrong. Primary endpoint were lower in the TAVR versus surgery, similar stroke rates between TAVR and surgery, similar rehospitalization in TAVR versus surgery, higher patient prostatic mismatch and lower AFib in the TAVR versus surgery. Clearly that in this particular case, the answer is C, the lower hospitalization. Then following are the true statement about the 3-year results of the Notion 2 trial, comparing TAVR versus surgery in younger, low risk AS patient, except primary outcomes are similar between 2. Primary outcomes tended to be higher than TAVR versus surgery in bicuspid cohort. Rehospitalization was similar between TAVR and surgery, and disabling stroke rates are statistically higher with TAVR versus surgery in bicuspid cohort, and answer that is D. It was not statistically higher, but just a very little trend. With that note, I complete our presentation for today, and we can take any other questions.
Fantastic, SS. We have a question for Dr. Akstam that came after your presentation, and is regarding the AL1 catheter when you decide to cross with AL. He wants to know exactly what kind of AL is this, 1 or 2, is 5 French or 6 French, is a guide or a diagnostic?
Let Sahil answer that question because he prompted that.
Yeah, so AR2 for most cases, diagnostic AR2 catheter, which is 5 French. AL1, if your sinuses are very big and the root is very big, diagnostic catheter. If you're crossing small valves or very eccentric openings, then you need precision. For that, the guide is better, and guide should be 6 French. Also, if you're crossing tall valves, so if you're crossing for a redo TAVR and you have a tall evolute valve, the guide will never cross the cells of that tall valve. So that's another benefit of using a guide in those cases. So your catheter may cross, but the guide will never cross. So you'll make sure you're actually in the center of the valve as you're crossing. So,
yeah, but otherwise, I mean, most of the time you can get away with the diagnostic AL, and it is a 5 French. We don't carry 6 French. It's a 5 French diagnostic AL1. AL2 will be if your aortic root is like 5+, which should not, rarely you have to do it because this was inoperable. But otherwise, AL1 is good, diagnostic, and of course, some cases you can use that's a 5 French. But if you're using the guide in a very difficult case, and particularly using cautery and other things I mentioned, that maybe the guide will be useful in those cases.
Great. Now, before closing, I have a great announcement that is coming December 11. So December 11, we have our New York Transcatheter Valve Symposium. It's a live presentation of 9 cases interacted with excellent speakers giving the different talks and, most important, the controversies. Having said that, you need to sign. You need to sign up right now at www.nytranscatheter.org. Now, in closing our case today, remember we have all these cases already built up for your review at www.livecases.org. Enter at the structural site. And we do these live cases, transcatheter live cases, every Tuesday, second Tuesday of the month. The next one will be December 9 at 9 a.m. See you then. Thank you so much. Yeah.
We have selected about 50 fellows. They are complimentary, and we take care of all their air, lodging, and travel. So once you select those 50 fellows, so that will be part of the symposium, because we want to encourage more and more fellows, because we have a 5 case presentation, and then we select from there judges that which is the best presenter. We get extra some raffle or some gift to take home. But key, the fellows are encouraged, and we have a limit of 50 fellows, which will be in which everything is paid for them.
Fantastic. Incredible generosity, Dr. Sharma. Thank you so much for that. And see you again December 9 at 9 a.m.
Thank you.